macroscopic level, they exist to kill. They travel, they attack, they hide, they even gather together in defense maneuvers. Pathogens are the enemies of every member of the healthcare team. On Pathogens and PPE, we give you the tools you need to fight these threats and win. So sit back, tune in, and let's make these microbes tremble at the sound of your name.
Everybody, we're here with the Pathogens and PPE podcast with Beyond Clean. My name is Jill Holdsworth. I'm the manager of infection prevention at Emory University Hospital Midtown in Atlanta, Georgia, and I'm here with my co-host, Patrick Gordon.
Hi, everybody. My name is Patrick Gordon. I am the director of infection control at Beth Israel Deaconess Medical Center in Boston, Massachusetts.
And we are here with an episode all about surgical site infections, and we've got a couple great guests here with us today, Jhmeid Billingslea and Jeri Culbertson. You don't want to miss this. We'll be right back to get started. Welcome, everybody, back to the Pathogens and PPE podcast with Beyond Clean. I am here with my co-host, Patrick, and my special guest, Jhmeid Billingslea and Jeri Culbertson. And I'm going to go ahead and ask if they will introduce themselves really quick. Jhmeid, why don't we go ahead and start with you?
Thank you, Jill. It is a pleasure to be on with you and Patrick, and honor. My name is Jhmeid Billingslea. I have been in the surgical services arena for 30-something years, and I know you're thinking, but you only look 32. Thank you for thinking that. I'm military trained, so started off as a surgical tech, became a first assistant, and then in my civilian career, I taught surgical tech and surgical assistants, and then I fell in love with sterile processing, and then I kind of got to know the interaction in the civilian world between IPs and surgical services, which is totally different from the military interaction. And so it was so fun because now you felt like you had a partner in that kind of best practice aim. So that's my story, and I'm sticking with it.
Awesome. How about you, Jeri?
So my start is actually similar to Jhmeid's. I started out as a surgical tech in the Army some 25 years ago. So worked both during a surgical case and then took care of the instruments afterwards. So long-standing history from that. Went into nursing and did a variety of things, but really fell in love with infection prevention. And because of my start in sterile processing in the OR, I've really navigated or gravitated to those areas within infection prevention. So I've been doing infection prevention for the last 8 or so years and really enjoying working with the crew.
That's amazing because I know both of you, and I had no idea that both of you had military background. So this is so cool that I just found that out about both of you on this podcast today. So awesome. All right. So let's go ahead and get started. I want to know from Jeri, what makes you so passionate about sterile processing? What really made you really like sterile processing in the first place?
Really, it comes down to me for the people that work there. They're putting their heart, their soul, their backs into all of this work, and they don't get the recognition that they deserve. Everything is coming down to, what they're producing and sending up to the OR. So when we look at the process, I really like to hear from the people doing the work and what their concerns are, what their frustrations are, and really just look at the processes. It's usually not an individual person that is struggling. There's usually more than one, and just really want to focus on the process to help improve their workflow.
Yeah, Jeri, I think that's great. One thing that we often say here is that CPD may be at the basement of the hospital, but that they're center of infection prevention. And I think your point about really talking the process through is important. I'd wonder how you help train new IPs that maybe don't have the background that you have, haven't worked in CPD, haven't worked in the OR, to get them to understand how they can help influence those processes down in CPD without being the technical experts.
Yeah, normally when I'm training other infection preventionists and talking to them about it, there's some fear with going into both sterile processing and the OR, just because it's a different world. They're not used to seeing those activities and what all is involved with it. And they're not educated on how many steps are actually involved from getting a dirty set all the way through. It's now back in the hands of a surgeon. So having them just be with me, be present and watching the process, not necessarily asking me the questions, but asking the SPD staff on what they're doing so that it comes from them on, how they're working through all these complicated steps in cleaning instruments.
That's awesome. Thanks so much, Jeri. I'm going to flip the question a little bit to ask Jhmeid, but I've seen you work, Jhmeid, with a lot of IPs, interact with a lot of IPs. So I'm going to ask you, what makes you feel so drawn to infection prevention when it comes to sterile processing, and why do you feel like it's so important?
Let me try to give you the elevator version of this story. So our IP for surgical services quit because we were so mean and bullying, and Jeri knows that sometimes in surgical services we are not the friendliest when people are offering criticism or constructive criticism. So they said, okay, we're going to appoint somebody else. The somebody else said, if you appoint me to the surgical services IP, I'm going to quit. So we went without an IP for like 6 months. So I was trying to do some of the stuff for the IP. And so when we finally identified a great IP who had never worked in surgical services, and they said, well, you help onboard her. And so I helped onboard her, and she had such a positive impact because what I helped the rest of the leaders in surgical services realize is the IP's knowledge of what's going on around the hospital is applicable to surgery, even though they don't have to be a surgical expert to bring that knowledge. And so she taught them some stuff about IP around the hospital that ended up helping us in our accreditation visit. And then we taught her some of the principles of surgery and sterile processing. And so since that point, I just realized that I wanted to be a part of the solution for IPs who were assigned to surgical services, because they can bring so much insight, and all they need is for us to let them get in the game, give them the ball, instead of keeping them on the bench and telling them what they don't know about surgery or SPD. So I just think it's the best partnership in the hospital, and it has so much impact around the hospital, not just in surgical services.
I gotta say, I love that answer. I think that's one of the most important things in terms of training IPs is just what you said, that we don't get people coming into infection prevention often that have worked in ORs for long periods of time or understand the ins and outs of what folks do in CPD. And crossing that threshold is the scariest part, right? So that's a really great point. I think a lot of folks can take that back to their facilities and understand that we just have to bring people to that space, get them comfortable of applying the principles of infection prevention in CPD in the OR, and folks will feel more comfortable after doing it once or twice. So I love that. Thank you.
And I love that you said you had someone assigned to surgical services. I thought that was amazing. I wish that we all could have an IP that was dedicated to surgical services. And maybe that's a best practice that everybody can take away from here. If you're an IP listening, maybe we need to make sure that everybody has an IP assigned to surgical services. I know staffing isn't always able to do that, but what a great idea.
Oh, it just pays so many dividends, because when you think about it, we're sterilizing products all over the hospital. The surgeons are not just doing surgery in the hospital, so they're touching ICUs, cardiac ICUs, and all that stuff. So if you can have an IP that is kind of the representative for that area, you can touch and prevent bad practices in other areas other than just the OR and SPD. And when you have that team and you have an IP that's developing that expertise, when you have someone like Jill or Patrick who are going to conferences for that particular area, the next thing you know, they're like, hey, I've heard about this. And then it's just helping further patient safety.
And to tag on to what Jhmeid said, I mean, I'm assigned to surgical services here as well. And I've really developed a relationship with not only the leadership here, but the staff. They're willing to come up to me and ask questions as I'm rounding through there. And so that relationship building is huge, and building that trust and collaboration amongst all members.
Yeah, fantastic. That's so important. And speaking of this, so since we're talking all about surgical site infections here, I want Jeri just to kind of start off for those who may not know that IPs do have certain requirements that we have to do surrounding surgical site infections and what we have to report. So, Jeri, if you could just kind of briefly explain to all of the people listening, what are kind of the required things that we have to report in SSIs, and what might be some of those extra things that we do surveillance on that we may not be required to report, but that we do anyways because they're still important?
Yeah, so for any facility that takes funds from CMS, which is most everybody, we are required to report at least at the bare minimum on hysterectomies and colons. So those are the two bare bones that the facilities must report their surgical site infections on. The other places, other state requirements maybe or local, is going to be more surrounded on what procedures they want to look at. I believe it's Pennsylvania that has to report every surgical procedure. So regardless of what it is, they're monitoring and watching it. Versus like other facilities have an option. So if you see kind of some unusual infections surrounding laminectomies or something, but you're not necessarily watching that for NHSM purposes and reporting to that organization in the CDC, it still gives you an opportunity then to drill down and decide, what are the steps involved? Where might there be some breakdowns and some gaps in practice, and what can we do to bring everything together?
Jeri, when you talk about SSIs that are different ones that are important, how would you recommend to somebody that's just getting into the field or may not have practiced in an acute care facility before, of talking to the providers and the care teams about these SSIs that aren't reportable, such as the laminectomies and other things that may be important but not in that reporting bucket? What's an approach that you take at your facility?
So really for me, I start with the leadership and just kind of see if they see anything on their end as to what might be driving it. Do we have a change in providers, a change in our chemistries that we're using in SPD? Just look to see if there's been any recent changes and kind of build off from there. And again, if that's all clear, then I go back and I look at the process and I am monitoring and not monitoring, that's not the right word, but observing their practices and kind of seeing if something maybe had changed from that aspect.
That's a perfect lead into the next question that I want to ask. I'm going to start with Jhmeid and saying, what kind of risk factors are we seeing or do you kind of go to first when someone might come to you, maybe an IP would come to you and say, we're having an increase in surgical site infections. What are your first risk factors that you might start to investigate when you hear somebody say that from your end?
So you know that I'm fortunate enough that I go into hospitals and do audits. And one of the things that I like to see is, what is their SSI investigation track? And what I often find is it's not detailed enough, right? So you're asking specifically about what the risk, like a specific risk. To me, the overall risk is, what information are you asking after you identify a SSI? So they go like, oh, we know it was this tray, and then we know it was this. Do we know which washer it was used? Do we know who wrapped it? Do we know who prepared it? Do we know how long it took from the case start to the start of intervention from a biofilm development? So a lot of times what you find is the SSI tracking form is such the bare minimum that there's no way that you can identify what the common risk factor is. And so what we do is we say, if you would ask these things, then you could kind of put them together and see, do we have some common risk factors? But obviously the biggest risk factor is the level of training for the staff on both sides, the OR and SPD. and the staffing levels. I mean, study after study shows that understaffed ORs and understaffed SPDs kind of correlate with SSIs. And that's the thing that we never take into the factor. We want it to be some magical solution that we're using, or we want some magical thing. But it's really, do we have enough people to do the job, and have we properly educated them to do the job? And if you look at those two factors from a third party view, not like what's your opinion, but what's their education and training? How many of these trays have they done before they touch this tray? Then you'll start finding out education and staffing levels are probably the two biggest risk factors to create some of those, that not cause it, but correlate with some of those SSI or tray errors that may result in an SSI or not result in an SSI. So I think that kind of variance tracking and SSI, you can't impact SSIs without looking at errors overall. And so a lot of times we don't want to do that, and we don't want to say these things have some connection, but they do.
I think you just hit the nail on the head right there with looking at the risk factors in SPD. A lot of our national recommendations that we have from infection control really focus on clinical epidemiology and look at things that may be able to be extracted from the medical record or processes that are happening in the OR, but we don't see a lot of information about processes that are happening in sterile processing. So if you could add to some of those national recommendations yourself, what would be, like, say, 3 to 5 variables that you think everyone should look at in their SPD outside of staffing when they go downstairs to review potential SSI risk?
Total processing time, which indicates the time from case in to the case ready, right? Because we know there's two opportunities for biofilm. You have the binary fission that's happening from the end of the case until you start manually cleaning the tray. But then the secret one is when a tray comes out of the washer, it's not sterile. It's high-level disinfected. So if that tray sits on the shelf for 6 days because it's not a high-use tray, or we don't need it it's a vendor tray, and we just wrap it up, okay, it was very low, but it was never zero. So where is it now? So those are like little practices that have an impact on the ability of the sterilant to work. So it would be like numbers like that. And I say, Patrick, I want to look at the overall error rate, right? Because errors are errors, right? You have the errors that we discover and the errors that may not be discovered. But so you have to have a quality program. So implementing a quality program that allows you to pull trace, particularly the ones that have high chances of bioburden, will give you a better idea of what really happens than just relying on the times that they were actually caught, or just looking at SSIs without looking at some of the other things that might contribute to those SSIs. So I would say those having a quality program that does quality checks and education based on those quality checks, those are one. And then looking at the time, the total processing time, because low total processing time means two different opportunities for the microbial load to really gang up on against the steam or low temperature sterilization. So those are just my things that I like to see.
Thanks, Jhmeid. I've never actually heard somebody say that, to look at the total processing time in correlation with surgical site infections. I actually find that really fascinating, and now am a little bit nervous to start digging into some of these extra metrics to see what we actually might find. And I agree with you. I think some of these just kind of overall quality programs are so important to look into and see what can we do to reduce overall biofilm? And this is just speaking to IP's language, like, what can we do to prevent infections, even though we may not be able to prove that we're preventing them? That's our life right here. We may not be able to prove that all this time we're spending doing all of these things saved money, prevented infections, prevented harm, even though we know that we're making a difference. So you're speaking our language right there. So thank you for that. Jeri, I want to kind of ask you the same thing, but to Patrick's point, can you explain for the listeners who may not know what some of those other risk factors are, some of those clinical risk factors that we are looking at when we are doing those chart reviews, or we're looking at some of those other initiatives that we're doing in pre-op and some of those things that we're more comfortable with as IPs that we are kind of dealing with every day?
Yeah, so there are some things that we have control over, and there's other things that we don't. And those that we don't have control over at the time of surgery are going to be, are they obese? Are there other comorbidities such as COPD or other risk factors that make it difficult for them or slower for them to even recover from a typical surgery? And then the other things are, we're looking at what's going on in the home. What prep do they need to do before they even step foot into, the OR? What's happening during the OR session? How many people are in the room? How many times is that door opening and closing? Those kinds of things. And then what's happening after? What does the wound care look like? What does the education that the patient received look like? Is it something that they were able to repeat back and understand? So it's not just the surgery itself. You can have a perfect surgery. You can have the perfect instruments that are being used, but there are many other things that come into play when we do look at different surgical site infections. And you can't always pinpoint, what's going on, but you can certainly look at trends to help identify what might be leading to higher infection rate.
Jeri, I think you started to hit upon it a little bit about the stuff that we do preoperatively and in the OR, but a lot of our SSIs we know are caused by skin flora or the bacteria on patients' own skin. Can you talk a little bit about the interventions that are routinely in place to reduce the risk of infection from patients' own skin flora?
Yeah, so essentially what we're looking to do is decolonize not only the skin, but the nares as well. So there's different ways to go about that from, CHG products. There's a silver-based product out there to work with the skin. But then when we're talking about the nares, we're looking at potentially an antibiotic or povidone iodine or an alcohol-based antiseptic. And all of that can be either done before the surgery in the home, or it can be done at the time of surgery when they come in. Or there's a combination too, where some practices will ask the patient to do this in front of their surgery, and then on the day of, they'll do it as well. And then even looking at the skin and nasal decolonization afterwards. So that can take a play on, if they're in the ICU and they have central lines and other invasive equipment that could contribute to bloodstream infections that could also then lead to a surgical site infection or vice versa. Reducing that skin and nasal flora is a really important component, and it's science-based as well. We have a lot of evidence that supports combining those two interventions to reduce surgical site infections.
Thanks so much to both of you. I think this really speaks to both ends of what we're really talking about here, the clinical risk factors, and then how SPD fits into this crazy puzzle of surgical site infections, and really starting to get into how can we start to prevent some more of these surgical site infections and really thinking outside of the box. And so I'm going to kind of wrap it up here with one kind of final big question that I'm not sure that I've heard the perfect answer to this yet, but I really want to start getting into some ways that we can solve this question. And Jhmeid, I'm going to start with you to give Jeri a break. But so how can we as IPs involve sterile processing more in the review process of these surgical site infections? I'm not sure we've really solved this yet. And I want us to really think about it as involving leadership down to the tech level. This is how we look at on the nursing side. So why not look at it that way on the sterile processing side? So what are your thoughts on that?
Wow, you just threw a fastball right down the middle. So Jeri did an incredible job of kind of going over the clinical factors, right? And so if you sit a leader or a mid-level leader or even a tech down and you translate that, and I know you guys know, and I think a lot of our listeners on this podcast will know, what are the clinical stuff? And so you want to know what room it was, what surgeon it was. And then when you look at typically what we're harvesting from SPD, you're like, wait, it's not the same specificity, right? It's like we want to know which room, which tech, which nurse, who came in from X-ray, but down at SPD, it doesn't matter. We just need to know when it was sterilized. And so when you look at those factors, you can say, oh, maybe we can provide this same level of detail to our report so that now the SSI report matches from both the clinical risk factors to the environmental risk factors. And the other way to make sure that gets done is start that partnership before you get an SSI, right? Jeri talked about rounding IPs. If your SPD doesn't want to round with you, if your OR doesn't round with you, you just round with them. You see that you round with them. You say, hey, is it okay if I go in? Because Jeri did a great job of telling us what can happen. The best thing that can happen to an SPD leader or even an OR leader is have an IP that's on their site and dedicated to looking throughout the place. Because we do all these clinical risk factors, but we walk right through a center core that's dirty, that's not up to the standards, and we're like, we just don't know why we're having high SSIs. So when you get that whole 360 view where IP is partnering with the surgical services group, and we're looking at everything. Let's not just look at the narrow thing of which sterilizer did it come out of and what time. What about the same details that we have in the OR? Oh, did they use the cleaner? Did they not use the cleaner? What time was so there's equivalence if you can talk through that for the SPD time, like with the antibiotics, all that stuff, there's an SPD equivalent. And so if you start expanding your mind about what information we need every time we get an SSI, it means that your SPD is going to start thinking, did we complete all the practices that we said that we were going to do? So I know that was a long answer, but I am passionate about IP and surgical services coming together. And, if you have an IP like Jeri, like Jill, like Patrick, you are already on the road to success, but welcome them in your door and you're going to enjoy the change.
We definitely love that answer. I think it's really, if we could bottle that up and send it out to all of our IP colleagues, it's something I would definitely love to do, because the reality is it's about walking through that door, introducing yourself and saying, hey, let me work with you, and you tell me what you know, I'll tell you what I know. We can work together. And I think that's what I'm hearing today, and what we've talked a lot about today, is that doesn't happen nearly enough. So thank you for that. And I hope our listeners can take this back to their facilities and just walk through that door and say, let's work together moving forward and start driving this change forward.
They need you. They need you.
Jeri, do you want to leave us with some parting wisdom about how you think we can involve our sterile processing colleagues more in our SSI reviews?
Yeah, I would love to see more sterile processing staff members take that initiative and go to your leadership to ask about SSIs, so that you can get on like a multidisciplinary team and participate, and then bring that information back to your team members so that you have a better understanding of what's happening outside of sterile processing. And you guys might see something that multidisciplinary doesn't see, because we're not bringing in that component of sterile processing. And you guys have the knowledge, the training, and it's so valuable when we're looking at the overall process of SSIs and what could go wrong and what can go right. So please take that initiative. You don't have to be a leader or in management. Just show some initiative and see where you can go with it.
What a great idea to have even just a subgroup within your department, like an SSI task force in the sterile processing department. If there isn't a group to join, I've never really thought about that, but how empowering.
Great idea.
For the sterile processing techs. I think that is such a fantastic idea. I'd love to hear from anybody who already has something like that going that we could showcase. I think that's absolutely fantastic. And I hope that somebody can walk away from this podcast and say, you know what, I'm going to go suggest that. I'm going to start it. Even if it's 2 people, start it. That's a task force. So I hope that we hear that somebody goes and they start it and they come up with some great ideas. I think that is an incredible thing to do. And that is about all the time that we have today. This has been such an incredible conversation. I have to give special thanks to Jeri and Jhmeid, our guests today. This was wonderful. And a big thank you to my co-host, Patrick Gordon. And we hope to see you on future episodes of Pathogens and PPE. Thank you all for listening. Bye-bye.
On today's episode, our guest talked to us about how we can pair together IP and SPD staff by just crossing that threshold, building that partnership, and starting to work together towards further SSI prevention.
We also talked about some of those risk factors that we can work on together. Some of those clinical risk factors that IPs look at all the time may not be ones that we can necessarily affect or change together, but some of those we can actually look at building a quality program in sterile processing and looking at some of those metrics like total processing time, overall error rates, and other things that we can work on to reduce biofilm and reducing harm to our patients. Our guests were really enthusiastic about starting IP and SPD relationships, working together and observing together, rounding together. These were all great ideas with starting partnerships, strengthening relationships, and preventing SSIs.
Don't forget to wash your hands.
And keep fighting dirty.
Thanks for tuning in to this exclusive podcast series on pathogens and PPE. For more information and clinical resources to help you fight dirty, make sure to follow us on social media by searching for Beyond Clean and Transmission Control.